Yeah, great. Well, I'd like to welcome everybody to the sixth in our series of Stanford Facial Plastic Surgery webinars. It's my pleasure this week to host a webinar on a very important topic, I think one that's often under-discussed, and that's functional rhinoplasty and advanced septal surgery. We have an international panel of experts from around the world. We have Dr. Wolfgang Gubisch from Germany, Dr. Sami Moubayed from Montreal, Canada, Dr. Kaete Archer from the US in New York, Dr. Garyfalia Lekakis in Belgium, Dr. Robin Lindsay out in Boston and Harvard, and Dr. Lucas Patrocinio from Brazil, who are all going to share their expertise with us. And I'm really excited about this because for me, thinking about rhinoplasty, the common definition is that this is an aesthetic surgery, but that's really, to my mind, really incorrect. Rhinoplasty surgery should always be thought of as both a functional and aesthetic surgery. Whether it's a functional patient for whom you're just doing a breathing operation, or an aesthetic patient, because you don't want to cause the opposite problem in those patients. You don't want to cause a functional patient to be concerned about their appearance too much afterwards, and the opposite is true, of course, for aesthetic patients. And so, when we think about doing a physical rhinoplasty, we're talking about this bony cartilaginous framework and the mucosa and the lining, which creates light and shadow, which gives an aesthetic contour. But there's this balance with function that we always have to consider. And so there's this tension in rhinoplasty between aesthetics and function. And to be a good rhinoplasty surgeon, you have to understand both aspects. Today is going to focus on the right side of the screen a bit to talk about function. I just want to spend a couple minutes talking about how we measure nasal function. And when we talk about this, I'm not talking about olfaction or other things. I'm talking about nasal airway. And there are three primary modalities in my mind for measuring the nasal airway: physical measures, which are quantitative measures of actual airflow; patient-derived measures, or patient-recorded outcome measures, or PROMs. If I say the word PROM, that's what I'm referring to. And of course, physician-derived measures, which are probably lacking. And these are grades and severity classifications for what you see anatomically inside of a nose. I have my own bias. I'm going to share it with you right now. This is a graph that I've shown in a few other webinars, and it's instructive because on the left side of the axis, the left axis shows nose scores, which is one of the most common PROMs used for rhinoplasty patients to measure obstruction. And a high score is bad, so it's a worse nasal obstruction symptom. And on the bottom, we have nasal peak airflow. And if you hypothesize that nasal obstruction correlates with airflow, in other words, the better airflow you have, then the lower nose score you'll have, then perhaps you'll see something like this, this type of data if you did this type of study on patients. This is actually a graph taken from a paper that I really like by Ed Weaver from over a decade ago when I was back at the University of Washington. And this isn't the actual data. I've modified this. This is what the actual data looks like. There isn't really a correlation between patient-reported outcome measures, at least the nose questionnaire is given in his study, and peak airflow. And so for that reason, and my own experience with patients, I don't usually use that. And I know that's a bias. I know that my colleagues in Europe and South America may disagree with me, or in Australia, but this is what I go by. So I use patient-reported outcome measures. And I know some of the other panelists do as well. And so the gold standard, I think, has been the nose questionnaire, which was done by Mickey Stewart back in 2004 with collaborators from around the country in the US. And it was validated in septoplasty and turbinate reduction. And it really is the gold standard. It's been translated all over the world. And I think it's a great questionnaire, but the problem is it doesn't measure aesthetics. And so one of the speakers today, Dr. Moubayed, took it under his own design and actually create a really well-validated questionnaire, which I really credit him for coming up with schnoz. I think that we spent more time going back and forth about it. I remember how excited he was when he came up with the SHNOS acronym for it, but it's actually a fantastically validated questionnaire that measures both aesthetics and function patients. And I'm just going to put in for that because I think it's a wonderful tool. And it's been translated in multiple languages, including by one of our other panelists into Portuguese. And finally, physician-derived measures. I think this is an area where we've tried to make some improvements over the years, and I think it's probably where more can be done. My personal bias is I don't like seeing internal valve and external valve, particularly external valve collapse. I prefer looking at the nose as follows. I like to think about dynamic versus static obstruction. I like to look medially or laterally. So static obstructions medially are septal deviations or narrowing of the internal valve that's static. And how can we treat that? It helps me think about how we're going to treat that. Static lateral obstruction is a medialized nasal bone, which could be iatrogenic, or inferior turbinate hypertrophy. Dynamic medial is very rare that weak in a patient who had a very floppy septum after septoplasty. I don't know if any of the other panelists have seen that. And of course, my big one is lateral wall insufficiency, which is a term which we coined back in 2006. And I think it's been widely adopted. And we look at two different zones for this. And I think Dr. Moubayed or others may be speaking about that. So I'm actually going to just skip talking about these a little bit in the interest of time. And I know Dr. Gubisch is really the world-renowned expert in extracorporeal septoplasty. So I don't really want to belabor that. So I'm going to actually just skip ahead and stop here because I want to make sure we have enough time for our panelists. And just say that, I'm really excited to have everyone here speaking. And I think we're going to start off with Dr. Moubayed. And I'll turn over sharing the screen to you, Sami.
Perfect. For the opportunity to talk about a topic that I really love and that I grew to love even more during my fellowship at Stanford. We're just going to talk about diagnosing and managing lateral wall insufficiency. Now, the lateral nasal wall is classically divided into two zones, which are internal valve or external valve. I go more by the zone 1 and zone 2 definitions, and that's what we're going to be talking about more during this talk. When we talk about zone 1, we're mainly referring to the area classically described as the internal nasal valve, which, in all the textbooks and all the exam questions and everything that we all are familiar with, is the area between the upper lateral cartilage and the septum, which should be between 10 and 15 degrees. But why do we talk about zone 1 is because it's not always a static or narrowing problem. Sometimes it can be collapsed or dynamic. We'll go back to that in a second. Zone 2, which is more closely related to the classic definition of the external valve, is really around the ala. So it's limited by the caudal septum, the medial crura, the ala rim, and the nasal floor. Okay, and again, you can have static problems, you can have dynamic problems. Classically, lateral wall insufficiency was described as a dynamic phenomenon, and this is the 2006 paper from Dr. Mose, and here on the right is one of my patients with lateral wall insufficiency. As we can see, mainly at the level of zone 1, the patient is dynamically collapsing, and there's a classification for this going from grade 0, no collapse, grade 1, less than 1/3 of collapse between the ala and the septum, grade 2, 1/3 and 2/3, and grade 3 more than 2/3 to complete collapse. And this can happen both higher up at the level of the internal valve or zone 1 or lower down at the level of the external valve. However, these patients not always have dynamic problems. Sometimes these issues can be static. So in terms of static issues, sometimes it can be due to trauma at the level of zone 1. It can be due to narrowing of the midvault. Zone 2, the most common static condition affecting zone 2 lower down is caudal septal deviations that we see a lot. And then we'll talk about dynamic collapse, which is more lateral wall insufficiency, is weakness in the lateral nasal wall, which prevents patients from breathing. And we'll go over a few examples of each one of these. But I'll mainly be spending more time on the dynamic collapse, lateral wall insufficiency. Now, static collapse at the level of zone 1, the most common thing that we see is a pinched midvault that can be corrected with spreader grafts, as you can see in the midvault of this lady, and her Schnau scores decreased preoperatively to postoperatively from 95% obstruction to 10% obstruction. I won't spend too much time on this. This is something we all are usually more familiar with. In terms of static collapse at the level of zone 2, by far the most common problem is caudal septal deviation. And I know Dr. Gubisch, I'm sure, has prepared a fantastic talk, and it's an honor to be on the same panel as the pioneer of extracorporeal septoplasty. So this is a standard extracorporeal septoplasty to correct caudal septal deviations. And these patients, I use the modified technique by Dr. Most, but we see an improvement in their schnoz obstruction scores going from 80% to 0% and for these patients. And you can actually also see an improvement in the external appearance of the nose, as caudal deviations sometimes cause an external deformity at the level of the nostrils. Now let's talk more about dynamic issues, okay, at the level of zone 1, at the level of zone 2. Very often these are combined. It's very rare, at least in my experience, that somebody has only collapse at the level of zone 2 and no collapse at the level of zone 1. So this is a patient where we can see collapse at the level of zone 1 and at the level of zone 2 preoperatively. We've published a paper a few years ago in our standard algorithm to treat collapse at the level of each one of these zones. I'm not going to say there's only one way of treating dynamic lateral wall insufficiency at each one of these zones, but traditionally what Sam Moubayed has been doing and what I've started doing in my practice is collapse at the level of zone 1. We try to treat with lateral crural strut graft, which is a graft of cartilage either from the septum or the rib that goes underneath the lateral crura to stabilize the airway higher up at the level of zone 1. And if there's collapse lower down, well, then we go more for rim grafts. There are other options, there are other grafts, but this is that I'm going to be showing a little bit here. So here we see a patient where we've dissected the mucosa of the vestibular lateral crura, and we sculpt a lateral crural strut graft that is precisely measured and then sutured into place, going from the tip area to the piriform aperture. And this helps stabilize zone 1. Whereas for patients with zone 2 collapse, well, we dissect precise pockets in the ala and again take solid pieces of cartilage either from the septum or the rib and place them in precise pockets. Okay, now these are free-floating alar rim grafts. Over the past year or so, I've mainly adopted articulated alar rim grafts, meaning that you suture the rim grafts to a tip graft, which not only stabilizes the airway at the level of the external valve, but also has a dramatic improvement of nasal tip contour. So it really enhances nasal tip shape and makes it look even much nicer, in my opinion, than just free-floating alar rim grafts. But as we can see with this technique, preoperatively, the patient was collapsing on both sides, much more severely on the left side than on the right side. And postoperatively, this is an early result, 1 month, that's when I had the video. But we can see that there's no collapse when he's breathing in and breathing out. And in our 44 patient study, in terms of groups 1 and groups 2, and we controlled these, we controlled patients that received rim grafts to zone 2 and lateral strut grafts to zone 1 with patients that had no obstruction before. We can see that patients that were treated with this strategy actually significantly improved, even up to 12 months after surgery, their nose scores. And this was prior to the schnoz. Now there's something I also would like to talk about, which is the absorbable nasal wall implant, which is kind of like a little PDS implant that you place in the lateral nasal wall. This is not available in Canada, so I personally have no experience with it. But based on published studies, there is improvement in nose scores and in nasal wall collapse when this Lateral implant is implanted into the lateral nasal wall under local anesthesia. So this could be an interesting adjunct, an interesting future direction in treatment of these conditions, but again, it's not available everywhere. And when it becomes available for us, for example, in Canada, it might not even be reimbursed by the public healthcare system. So more studies to come according to this. Now, finally, I'd like to again remind you that zone and zone 2 is not always a dynamic phenomenon. Sometimes patients can have static problems. Each one of these conditions has specific methods of treating them. I'm not saying there's only one way of treating this, but proper diagnosis is probably the most important thing to be able to choose a proper treatment strategy. Thank you so much, and I'll let the next panelist continue.
Thank you very much, Dr. Moubayed. That's a really nice summary and also being on time. That was great. And, you know, just a quick comment about the Lateral, you know, I don't have any conflict of interest. I had said I had no conflict of interest because I no longer am a consultant, but I was a consultant for that company and I was involved in that study that you showed. It's an interesting device. I think that in the short term, it does, and it's, you know, one of the problems we're running into with is just how to bill for it, how to do the reimbursement and all that kind of stuff. But it's a nice alternative, I think, for some patients who don't want to undergo a surgical procedure and just need something to stiffen the lateral nasal wall. And you know what you said at the end about proper diagnosis is just so important. You know, this modified caudal maneuver referred to me for lapping or something that the otolaryngologist in the community or what has the nasal wall, and as they can breathe better or they have their skin, and you know, and much because that everybody, you know, so really I think what really needs to be done for lateral wall insufficiency, if you're trying to make a diagnosis for a patient as to whether surgery is really going to help them, is to stabilize the lateral nasal wall and have them inhale, like your patient you showed. If you stabilize his ala and he breathes better when you hold that out, then that surgery is going to help. Because I haven't yet found with that you can actually lateralize the nasal wall. Now, some exceptions are recurvature of the lateral crus that you can clip and fix or things like that. But in general, simply, you know, opening up that nose isn't going to be very diagnostic. I'm wondering if any of the panelists have any comments about that. Muted, Filio.
Sure. So yeah, I mean, I actually find that the caudal maneuver can be useful when a deviated septum. So you can decide that. Well,
you can open it up a little bit. Yeah. Robin, were you going to say something?
I agree. I think that, you know, a lot of times they're represented and it's really more stabilization. The other thing that I'll have, because that's been their nose for a lifetime, they don't really appreciate their symptoms of nasal obstruction. So I'll have them just buy a box of Breathe Right strips and have them try them for a couple nights to see what it feels like. I also find when I have them use Breathe Right strips, I make sure that they're using them on the kind of lower floppy part of the nose, because the directions I think are confusing and they typically will wear them too high. I think that just gives a picture of what surgery, if they're trying to decide if surgery is right for them or not.
Right.
I meant this answer because all nasal dilators that also I compared with PNIF and Vascors, the Breathe Right, but also 3 internal dilators, and I found Max was, I have you know, disclosed with the company, but I just found that Max was in terms of PNIF and Vascor, and also kind of more sort of patient friendly, because there were some other devices that they were not soft and not so easy to treat. I also do that if I have an external nasal collapse patient, you know, that's been waiting for a while. I'd give the nasal dilator and I'd say that this will mimic more or less the functional outcome of the surgery, and that helps. But of course, you know, I think tolerance is a big issue with those patients with comorbidity, or for patients that, you know, are not willing to undergo big surgery, depleted in cartilage, and undergo the whole, a nasal dilator can be, you know, a more conservative approach, but also a solution.
I'm not familiar with that brand. What does dilator look like?
The Dutch brand. It's in the box. One is orange, the other one is light blue. And it all goes internally, but it's rather soft, and it's well tolerated. But of course it can, so we advise them to put some Vaseline to keep humidity in the nose, because the nose can get dry. And it was out of three in total intranasal dilators that I used the best in terms of outcome and in terms also of tolerance.
Interesting. Okay, so I think we should move on now. It's my pleasure to introduce Dr. Kaete Archer, who's going to talk to us about, what I often combine with my rhinology colleagues, which is looking at functional endoscopic sinus surgery. And so, Kaete, thank you for coming.
Yes, we have rhinoplasty surgery. Okay, I think that's working. Okay, well, hello everyone, and the opportunity to participate in this webinar today. And I'm going to be talking about endoscopic sinus surgery and functional rhinoplasty. In New York, my practice is very much a fusion of general ENT and facial plastic surgery. So it's not uncommon for patients to come in and present with recurrent sinus infections, chronic sinusitis, and poorly controlled nasal allergies. When they get into the consultation room, that's when we identify structural issues that the other panelists are going to be talking more about today: caudal septal deviations, lateral wall insufficiencies, and narrowing or collapsed nasal valves. As rhinoplasty surgeons, it's important to appreciate the fact that all three of these dimensions can contribute to the overall health and functionality of the nose and the sinuses. All three of these dimensions can contribute to a patient's functional outcomes and quality of life measures. And we're all familiar with the internal nasal valve. The three main components, of course, are the caudal septum, the upper lateral cartilage, and the anterior head of the inferior turbinate. Whenever I see a patient in the office who has inferior turbinate hypertrophy, I'm thinking in the back of my mind, is there an underlying condition that is creating this mucosal inflammation? Is there an underlying condition that's contributing to this chronic irritation of the nose? And in general, we call that rhinitis, simply inflammation of the nose, inflammation of the mucosal lining. There's two main categories. The first one is allergic, and that's very self-explanatory. The second one is non-allergic rhinitis, and there's a host of different categories that we'll encounter in our everyday lives. Changes in air temperature and humidity, certain foods that we eat, occupational exposures, or a moldy building, hormone changes, hypothyroidism. And a lot of medications have as a side effect medication-related rhinitis that your patients will be on. Beta blockers, antidepressants, NSAIDs, ACE inhibitors, and the list goes on. So this is a patient who presented. It's the right and left endoscopic view of the nose. And of course, on the right, very obvious, you have this buckled caudal septal deviation. And on the left side, you have this massive inferior turbinate hypertrophy taking up all of that space. When you ask him more questions about his nasal history, we found out that he self-reported a cherry allergy, and he developed that cherry allergy 6 months after moving to New York. He's never been tested for allergies before. But of course, when you do an allergy panel on him, it's massively positive. But he sort of self-reported some expected nasal symptoms related to allergies. So when you're putting together a treatment plan for this patient, of course, we're performing an open approach to a caudal septoplasty. We're addressing the inferior turbinates. So you can take this little skinny nasal valve area and open it up into a larger airway. But at the same time, we're getting him on immunotherapy and an aggressive allergy campaign for treatment, because we want to maximize those long-term functional treatment outcomes of these patients once we've addressed the structural, more static issues. The reason we fuss about rhinitis when it comes to rhinoplasty surgery is that Rhinitis can directly create sinus problems. Anything that inflames or irritates the nose is going to lead to congestion, excess mucus production. Those sinus outflow tracts are going to become narrowed, and then that extra mucus production gets blocked into the sinus and sets you up for long-term or fluctuating sinus conditions and sinus infections. And it really all comes down to mucus regulation in the sinuses. This is a schematic diagram of the right maxillary sinus, and you can tell from the arrows that no matter where the mucus is in that sinus, the mucociliary clearance is going to move that mucus to the natural sinus ostium only. This means that if you create a hole or opening anywhere else in the maxillary sinus, the mucus will not drain out there naturally. And this has serious surgical implications when you're dealing with the health and functionality of the nose and sinuses. This is a patient who presented with recurrent sinusitis and snoring issues. He has a history of balloon sinuplasty. And of course, in the office, you immediately identify the problem with the deviated caudal septum. We obtained a CAT scan because of his history of sinusitis, and you can see right away a couple of specific findings. Inferior turbinate hypertrophy on the left side, he has some mucosal thickening of the sinus lining, and he has this big blob of mucus that's sitting in the outflow tract of the left maxillary sinus, which immediately leads us to think about the mucus regulation of this sinus. So we set him up for a septoplasty, open septoplasty, endoscopic sinus surgery, and turbinate reduction. This is an endoscopic view into the left middle meatus area, and I won't terrify you with a video of sinus surgery, but this is about where the natural sinus ostium is of the maxillary sinus. We take down the uncinate process, and this is what we immediately find. This is the natural ostium of the maxillary sinus. However, just posterior and inferior to that is either an accessory ostium or an iatrogenically created ostium from his previous surgery. So the problem that this sets patients up with is that the mucus is going to drain out of the natural ostium and then down and fall back into the maxillary sinus, creating a condition called recirculation of mucus. So the treatment is to simply take down this bridge of mucosa and bone and open it up into one large sinus opening, which will immediately address that functionality of the sinus and the overall health of the nose. This is another patient who presented with nasal obstruction, a history of nasal trauma, and vague sinus complaints. You can see from a structural standpoint, she has a bit of an inverted V deformity. She's got angulated nasal bone. She has a bony ridge on the left side and a little bit of nasal valve collapse on the left side as well. We identified a caudal septal, a little bit of a septal deviation. We put the nasal endoscope into her nose in the office because of the history of sinusitis complaints, and we see on this radiographic image this polyp, which is a little bit of an aggressive level of mucosal disease. So we obtain a CT scan, and if you scroll posteriorly on this CAT scan, you're seeing that the polyp becomes larger, some mucosal disease is creeping up in the maxillary sinus, and then posterior to that, you find this. This is a completely obstructed right maxillary sinus and a syndrome called silent sinus syndrome. It's a triad of 3 different things, and it happens when the outflow tract of the maxillary sinus becomes obstructed, setting up a negative intrasinus pressure that's going to pull in or retract the uncinate process, drop down the orbital floor, and contract this maxillary sinus into this little hypoplastic sinus. If left unaddressed, this process is going to propagate over time and can even lead to become so severe that it creates diplopia in patients. The only treatment for this is opening up this sinus. So again, endoscopic view into the right nasal cavity, take down the uncinate, open up that maxillary sinus, and a little bit into the anterior ethmoids. From a rhinoplasty standpoint, we performed at the same time bilateral spreader grafts, a little bit of rasting, median lateral osteotomy, cephalic, trim, a little bit of tip sutures, a base columella suture, and then it reduces and produces into just a better supported and better functioning nose. This is a younger patient presented with nasal trauma after lacrosse and also some vague sinus complaints. On physical examination, she has deviated nasal bones, again, a nasal bony ridge here, and a little bit of collapse of the nasal valve. Her CT scan shows that nasal fracture creating that bony ridge on the dorsum. She's got a deviated septum, moderate turbinate hypertrophy, little bit of mild mucosal thickening. She's got a blob of sinus coming out of her maxillary sinus there, a blob of mucus, a little bit of anterior ethmoid disease in this bony spur. So for her, we're performing septoplasty, sinus surgery, rhinoplasty, closed nasal reduction, and turbinate reduction. This is her diagram here, pretty straightforward functional rhinoplasty. Asymmetrical spreader grafts, a little bit of crushed cartilage grafting, rasping, medial and lateral osteotomies, took out that posterior bony spur. And here she is just 10 days after surgery, so she's still swollen and thick. And of course, you can tell this is a recent case, being careful with the coronavirus. But we've addressed sort of that bony spur, opened up the nose and the sinuses to create a comprehensive, better functioning nose. On her, she also had some mild sinus disease in the sphenoids and in the frontal sinuses. So we set her up for navigation at the same time. The AAO has a couple of indications specifically for image guidance, but essentially it's anything that can get dicey. And when it comes to rhinoplasty and being rhinoplasty surgeons, style points count. And I'm telling you, when you're in these sinuses and you hit the skull base or the optic canal or the carotid artery, you're going to lose style points. So I use navigation anytime I'm in the sphenoid, the posterior ethmoids, or the frontal sinuses these days. And if you're going to set up a navigation case with a rhinoplasty case, there's a little bit of logistical considerations to take into account. When you're setting up navigation, you register and calibrate based on the anatomy across the bridge of the nose and across the bony landmarks of the forehead. You check your accuracy based on the tip of the nose, the columella lip junction, and the glabella. So if you're going to register your navigation, you need to perform your sinus surgery immediately afterwards. If you perform your navigation and calibration, and then you do cosmetic changes of your rhinoplasty, adjusting the tip, changing the nasal bones, changing the glabella, changing the columella, you're going to throw off the accuracy a bit of your navigation. So on her, we did septoplasty, navigation, sinus surgery, rhinoplasty, and then the turbinate reduction at the end. And this is the last patient I'll mention. He was referred for nasal obstruction and vague facial pressure type of complaints. Radiographic view of some physical exam findings. He has this pinchy nasal valve, little bit of a deviated septum. So yes, there are definite structural issues going on, but then in his history, when you ask a little bit more about his nasal complaints and other medical conditions, he has out of control asthma that's not controlled, and he has out of control allergies, and he's been on every medication possible without any improvement. You put a scope in his nose and he just has massive polypoid edema of all of the nasal mucosa everywhere. And of course we get a CAT scan and it just shows massive nasal polyps and sinus disease. There is no amount of spreader grafting or sinus or septum surgery that is going to fully address the health and functionality of this nose and this patient. So I guess the take-home point of my bit of the webinar is that even as rhinoplasty surgeons, we have to appreciate that mucosal issues in rhinitis and sinus disease can also contribute to the overall health and functionality of the nose. Rhinoplasty is already such a challenging surgery, and the outcomes already have a certain level of unpredictability of them. So at least thinking about those other factors that may be playing a role in the functionality of your patient's nose will give you every opportunity to optimize the outcomes and those longer term outcomes for managing some of these functional issues. If you don't do sinus surgery, you don't have a history of ENT, it's very easy to do these combined cases, and it's very straightforward to team up with another surgeon who may do them more on a regular basis. It doesn't prolong the recovery time of patients or really add any other restrictions or recovery type of issues. And that's all I have.
Thank you very much, Dr. Archer. That's really great. And, you know, it's a good perspective to have. I don't think too many of us still do both functional endoscopic sinus surgery and rhinoplasty. I know the first 4 years, I'm old enough now that I can talk about various phases of my practice. So the first 4 years of my practice, I did. But when I moved from University of Washington down to Stanford, I had a couple of great colleagues, particularly Dr. Peter Wong and Zara Patel, and they like to do it, so we combine. I just want to say I liked your comment about style points if you hit the carotid. I thought you lose a lot more than style points if you hit the carotid. Yeah, but
style points plus.
I'm glad I don't really have to worry about that anymore. I have a couple of questions. You know, patients often come in with very allergic looking noses, clearly reactive to environmental stimuli, not that are not non-allergic. In other words, they clearly are allergic, but they're negative on their testing. Do you see that, and do you still treat these patients with the traditional sort of anti-allergic oral and nasal meds, or what advice do you give those people?
I do. If we always start with the skin test, and if the skin test is negative, but they swear up and down they have allergies, then we'll go for the RAST panel unless it's really clear cut. The RAST will allow us to test for food allergies in addition to the environmental allergies that we would do on a skin test. There's non-allergic rhinitis with eosinophilia syndrome, which of course is not a histamine-related response. It's an eosinophilia type of dysregulation, but you still treat them in the same way with a nasal steroid or oral steroids as needed. I'm not really doing histamine therapy unless I have either a very, very specific history that the patient gives. I go outside in the springtime at the time my pollen is going and I get allergies. And if they get better on a histamine, that's great. But if they trial the histamine and it doesn't work, I don't continue to do the histamine treatments. I'll try different steroid medications, nasal saline rinses, budesonide respules, and a Neomed sinus rinse. If I could have every sinus patient or rhinoplasty patient on one thing, it would be a Neomed.
And finally, can you just comment on, I know a lot of people worry about this, doing a rhino operation with various grafts and things in somebody who has chronic sinusitis and infection. I don't think studies really shown that there's much of a risk there, but I'm not sure. What is your advice to people? When you treat patients, are you concerned about that? And do you have any comments about that?
But I haven't had any problems. If I have a nasal polyposis type nose, I'm going to get those down with a course of steroids for 2 to 3 weeks before surgery, almost like a chemical polypectomy before I'm doing rhinoplasty. And then of course, there's the second issue of, are these steroids at the rhinoplasty that you may be doing at the same time? I may put patients operatively on an antibiotic in a chronic sinus patient. It's not active bacterial infections. It's the fact that the nasal mucosal lining is obstructed and they have chronic pressure concerns, headaches, and it's more about mucosal disease versus an active preoperatively on of antibiotics. If in the past they've really responded to antibiotics, they call the office and sinus infection, I'll just go ahead and decrease that bacterial load before their surgery. I haven't had any specific complications of doing them together in terms of post-op infection.
Okay, that's great. Any other panelists have any questions at all?
I have a comment. I think that's a great talk and a great topic to talk about, because I would say even in my practice right now, so many times I've had a patient sent to me by a sinus surgeon for something would seem to be like a caudal deviation post-septal, require maybe a rib graft or something. But since I started, every single one of my patients that requires any extensive revision functional rhinoplasty work, they all get the same baseline CT scan, allergy testing, nasal endoscopy. And more often than I remember, I end up finding associated CRS, associated allergic rhinitis. Sometimes when you treat just that, the patient ends up being better and does not require any extensive functional rhinoplasty. And sometimes even when the patient has problems only at night, and you'll ask them about snoring, fatigue, and then I'll ask for sleep studies. Some of these end up being just sleep apnea, and you treat sleep apnea and they end up not even requiring revision functional rhinoplasty. So I think it's very often a red herring that we see a caudal septum and we get sent the patient. If you just investigate and push a little bit more and try to find that associated disease or allergic rhinitis and treat that, they end up doing better and don't even need your.
What's your threat for getting a CT scan on these? When do you order a CT scan with someone presenting for nasal obstruction? When do you not?
If they have a history of sinus infections 3 to 4 the previous year, or they feel like they've been on 4 to 5 courses of antibiotics and they still haven't improved what their symptoms are, or if I put the nasal endoscope in and I'm seeing something like polyp or massive polypoid edema, I'll get a CT scan.
My threshold, any revision? or any other sinus symptom than obstruction. If they have a little bit of pressure, a little bit of congestion, a little bit too much discharge, just go for the CT scan.
Sam, I would like to add, I have a lot of patients with CRS from trauma. Trauma cases, rhinoplasty, secondary recurrent trauma, and CRS. It's a good operation. The patients here are very nice because we have to open the sinus and do everything. I do both surgeries at the same time. The problem is just the length. You have to be careful with the length. Sometimes we have frontal sinus, graft tree at the same time of a rhinoplasty, so it takes too much time. Just this remark.
Can I also comment?
Yeah.
I think it's really great to have this global view of nasal obstruction and mucosal disease, which is a component, or it can be a component, because it's also important to clarify to the patient that the rhinoplasty cannot treat mucosal disease. And therefore, if there is mucosal disease, it's prudent to diagnose it beforehand, to treat it, because it will not contribute to and make that very clear. On the other part of scanning, I scan everybody, even for nasal obstruction, but that is because my practice is more rhinoplasty oriented, and I'll use the scan by Yves Saban and other leaders in the field that and Enrico Robo. Scan is like as for sinus surgery too. So, you know, I suppose sometimes diagnosed what appeared to be papilloma, a sinus that the patient was, you know, not complaining about any, was not giving any symptoms. So sometimes you have that odd case. Sometimes you might find some sinus disease that's not necessarily severe and that doesn't necessarily dictate a surgical approach. I would use it just
I think that's Lucas. Lucas, could you mute your second? There you go.
Yeah, that's a great
Sorry.
point.
Sorry.
Yeah, I've seen Yves and others in your rhinoplasty patient. I'm really not there yet. I have to say I'm not so sure that it's cost effective. I know it's a low radiation dose. I think it's interesting from a study perspective to do that on a bunch of rhinoplasty patients. Hey, that insurers in the U.S. are going to pay for every patient that comes through to get a CT scan. It's just not going to happen. And perhaps rightfully so. I mean, I think the incidences you talked about, like the inverted papilloma and things like that, you know, they're always like that, but you have to really look at how many of those things you're going to catch and how much changes the way you do your surgery. But I may be wrong. I may be looking back at this Zoom in a couple of years and saying I was completely wrong. But right now, I don't quite see that. But only from a research perspective, when I went on my rhinoplasty patients and then looking at them afterwards, I think that'd be really cool. But I haven't really gotten to that from a diagnostic point of view. But Felix, to move on to you, I think so. It's a pleasure to have Dr. Lekakis here, who is a preeminent researcher, well, and a specialist who comes to us from Belgium. And thank you very much for joining us. What time is it there now? It's evening?
So it's a quarter to 7.
Okay, all right. Well, it's dinner time, so we need to let you speak so you can get some food.
Can you see my screen?
It is dark.
Okay, so let's see. Something is going wrong here.
Sometimes when Keynote does this, there you go.
Okay, is that, can you see that?
Yes.
Yeah. Okay. Thank you very much for the introduction, and thank you for inviting me. It's an honor to be part of this webinar, and a lot of kudos to you, Dr. Most, and to the Division of Facial Plastic and Reconstructive Surgery from Stanford University for organizing these amazing webinars and for continuing medical education online. So congratulations to all of you and your team. So I think it's a very nice topic and an important topic, of course, advanced septal surgery as part of functional rhinoplasty. And I'll be focusing more on bone grafts and their use in rhinoplasty. I have no disclosures for the talk, and I will be touching upon literature, anatomy of the septum, how to harvest bony septum, the indications of bony grafts in the nose in some of my cases. So if we look at the literature, we can spot that bony grafts and bone recycling in the nose is not a novel concept, and Jack Seen was actually writing about it in 1975. I was quite, I saw that, and even back then was not a new technique. But if we look closer, we will see real masters of rhinoplasty, such as Hossam Foda and Wolfgang Gubisch, who's with us today, and Fazl Apaidin, that have all been written on the same subject, on the same topic. So a little bit on anatomy, and of course we all know that septum is composed of the quadrangular cartilage, and there are 5 bones around it. It's the premaxilla, the crest of the maxillary bone, the crest of the palatine bone, the vomer, and the perpendicular plate. And this is all courtesy of the nice anatomical atlas of rhinoplasty by Peter Palhasi and by Roland Daniel. I've taken those pictures from this textbook. And I think septum is such an elusive and key structure for the nose because it's often hidden, but its shape will have important consequences for breathing and aesthetics, particularly if the leading edge caudally or anteriorly involved. And we see here this nice classification by Bowman Gyron based on shape, whether C or S shape. But I think it's important because it allows us to conceptualize the deformity, and no matter whether the deformity is primary, secondary, post-traumatic, or cleft nose, which is a category on its own, these type of classifications help. But what about the bony part? So essentially the perpendicular plate of the ethmoid is thin and flat lamina. However, bony deviations do exist, and that's another picture you'll see here on the 3rd column of a deviation of the perpendicular plate of the ethmoid from the same textbook. And so the question is, how do we go about it? And in another picture from the same book, we can appreciate the intimate relation between the perpendicular plate and the cribriform plate, which makes, if you like, the area very delicate, and also instrumentation in this area very exciting for us, as any twisting around that area can distract the cribriform plate with the consequences of a CSF leak that we all want to avoid. So classically, the teaching has been that we will use bony cutters in the form of Kaplan scissors or the Mayo scissors, and we will rotate the instrument downwards. But of course, power tools have taken over a little bit, and you can use just a simple Niedermann bear or piezo tools that have actually made surgery in that area more accurate and less risky. And this is courtesy of Olivier Zerbeau, which demonstrates the use of the long insert of the piezo and how to do an osteotomy, a high osteotomy on the septum, more anteriorly, if you like, and a more posterior osteotomy, and again, joining these 2 lines in order to get a graft that will incorporate some of the perpendicular plate of the ethmoid with no risk. So indications of bone grafts in rhinoplasty: you can use it as a splinting graft to support your septal cartilage, to strengthen a severe septal caudal deviation. You can also use it as a splinting spreader graft in a crooked nose, especially when you combine it with an out fracture or whatever needs to be done in terms of osteotomies. or even to strengthen your L strut, or even as part of your subtotal septal reconstruction. So this lady actually came to see me with severe nasal obstruction, and no, she was a post-trauma case and no aesthetic considerations at all, which was the reason that I don't have any pictures of her. But subsequently, I thought a lot about it, that maybe I should be photographing septoplasty patients too. So this is what I did for her. It was an open approach because her septum was so severely deviated. I wasn't sure I would be able to manage it in a closed approach. So I opened the nose and I found a fracture line at 2.7 centimeters from the caudal edge, which was perpendicular to the dorsum. And that was deviating the caudal part of her septum to the left. And then I found a second fracture line a little bit more posteriorly that was causing a deviation to the right. I luckily, with power instrumentation, managed to harvest part of her septum posterior to the second fracture line, but also part of her perpendicular plate. And I used 2 grafts, like a sandwich form, in order to straighten her septum and in order to reinforce it as sort of to laminate it. And luckily enough, I have a picture. This was an intraoperative picture. So I made some holes with the Lindman bears on the bony part of the hybrid graft, and I used the hybrid graft on the left side and just pure cartilage on the right. And this resolved her problems. She was extremely satisfied, but then again, I have no pictures of her. However, this is another patient on the table following just septoplasty, and it's only to show that sometimes with septoplasty, we can achieve a lot. And I think we can discuss I'd like to hear about you, what you do, whether you photograph your septoplasty patients. So this guy, this young man came to see me because he also had a severe nasal obstruction on the left side of his nose mainly, but also he had a deviated nose that he wanted to improve. And if you look closer on the frontal view, you will notice that he has a high septal deviation to the left and his tip is deviating to the right. He has a wide tip and also asymmetry as far as the nostrils are concerned, and a deviated columella. He has a prominence in the lateral keystone area on the left side, and his bones there are more convex. And this is also information that I get from the CT scan, which is one of the reasons I do it for every single rhinoplasty patient that comes through the door. On the profile view, we will appreciate his hump and his columella show, which is more prominent on the right side, because again, his caudal deflection was doing that to the right as it was pushing the medial crura more caudally. On the bird's view, we can appreciate the broken and asymmetric brow tip aesthetic lines. And on the 3/4 view, once again, his hump, his asymmetric tip, his wide tip, and the columella show. So what I did for him, I did an open structural septorhinoplasty. So following separation of the upper laterals from the upper lateral cartilage from the septum, I did a component hump reduction. I harvested some septum, respecting a 2 centimeter L strut dorsally and caudally. He did have an excessive height of his septum, so I had to reduce with an inferior strip the height of his septum, but also I took a couple of millimeters of his caudal septum out, just a short strip. I did asymmetric osteotomies, of course, to correct his deviation. On the left side, I did a low to low osteotomy with piezo, and I did an incomplete transverse osteotomy. And I did ostectomy or osteoplasty to actually smoothen out that convexity that was more prominent on the left lateral keystone area that I explained earlier. On the right side, I did a lateral osteotomy of partial thickness, a transverse osteotomy and a paramedian osteotomy, and that helped me to outfracture that side. I also introduced a spreader graft, which was hybrid, So part of it was bony, part of it was cartilaginous. So the bony part, of course, I introduced, and the reconstruction of the middle vault was completed with bilateral spreader flaps. I also introduced a septal extension graft, which was secured and fixed on the right side of the septum. That was the concave side. I secured the posterior septal angle on the anterior nasal spine with PDS, and I sutured his medial cruri in a tongue and groove fashion at the caudal part of the septal extension graft. So I think I have maybe, I hope that plays a video. Yes, so I'm actually using, this is a different patient because I had no opportunity for video recording on the previous one, but it was the same sort of act with the long piece of the piezo, which I was using at that time, was only trying it out. This was not piezo I owned at the time. It was I believe by Mectron, which is an Italian company. Again, no disclosures here, but I happened to use this particular piece and I found it extremely useful for bony, for the posterior part of the septum. It made me feel very comfortable working in this area and getting out a graft long enough with a bony component that can be useful. So this is actually the guy that you saw in the picture, and this was what his graft looked like. And you can see that I have designed the spreader grafts equally being hybrid. In other words, using part of the bone. You can also shape these grafts with the piezo. I have another short video, and this is only to show that I would use the ligament bear to open a hole on the anterior nasal spine. But this you can also use with a special insert from piezo. So I think power instrumentation is also helping on that front. So this guy is 10 months out. It's an early result, has a straighter looking nose, and this convexity there is looking better. His tip is also more refined and more symmetric, not perfect, surely not perfect. On the bird's view, we can see that these broken aesthetic lines are actually better. On the basal view, we can see that again, the columella is less deviated and his tip is more refined. On the lateral view, he has a straighter dorsum. On the other side, his columella show has improved. And on the 3/4 view, left and right. So in conclusion, membranous bone harvested from nasal septum as a graft will increase our repertoire of techniques. I think it can be a wonderful adjunct for correction of the deviated nose, and sometimes it can obviate the need to perform bigger procedures. And thank you for your attention.
Thank you very much, Dr. Lekakis. It's really great to have you. And I think that was a very nice talk and very nice idea about using bone. And of course, this new instrumentation makes it much safer, I think, makes people much more comfortable with harvesting close to the skull base. You know, in the patient, the before and after, but in the before, when I was looking at it, you know, one thing that I look at in all my patients, and of course, I'm sure you do a smiling view with the dentition visible as well. I see craniofacial asymmetries in everybody. And where I know Lucas is going to talk about this in a little bit, but when I look at that patient, I see a difference in right mid-facial height. And I see some things at the base of the nose that are, you know, part of probably the cause. And I think there was a study out of Tehran of some plastic surgeons in Iran who did analyze patients for facial asymmetries and noticed that the nose more often than not deviates to the shorter mid-facial side. I've noticed also in my patients. Have you noticed anything like that? And do you kind of analyze that? And this is going, I guess, goes towards your CT scan comment, because that would probably show it too. But I see it on the external landmarks.
Yes, absolutely. It's a very good comment. Yes, I think the more you analyze the face, the more you you see these things, and I think it's important, again, from the education point of view to the patient, to point them out and to explain that these are overall limitations to achieve a perfect result, or to give them an absolute, 100% straight nose, which is impossible more often than not.
Actually, that's exactly what my next question for you was going to be, which is, how do you counsel patients with asymmetric noses?
I never, well, of course,
the outcome expectations.
Yeah, the golden rule in facial plastic surgery to underpromise and overdeliver. So sort of try to tame down expectations, but I think that's something that you kind of judge in the consultation process. And when I do simulation, I kind of see how they react, and that's helping me a lot. If they if they are happy. I've lost you there, but are you still with me?
Yes.
Of my presentation, but I don't see. But as long as you hear me continue talking,
we can see and hear you.
Yeah. Okay. So simulation for me, I don't do I avoid actually perfect simulation. So I just do little corrections and I see how they react. If they seem to be happy and positive, I take them on board and I consider them good candidates. They are very picky, don't like even the simulation, they even reject that patient based on how they react on the simulation.
I'm with you 100%. And but the patients sometimes seem to know, patients where I counsel them that, it's not going to be 100% straight afterward. And, they get what I consider pretty good. I don't expect perfection.
Yeah.
and I just wanted to take my head and just bang it against the wall for about an hour. But, because I do go out of my way to point that out. End of the day, my throat, my voice is hoarse because I've said it so many times. But yeah, I have a couple questions that came from the audience for you. Okay, let's see here. How do you address high septal deviations using a closed septoplasty technique? I think you showed somebody who ended up straighter.
Yeah, actually, this was a guy, I don't remember what I did with him. It was just a picture that I had. I don't, his surgery very much, but this guy I didn't open. Certainly the user can be useful, or not correct everything with just a bone graft and a closed septoplasty. I mean, the last guy you saw, osteotomy, is a deviated just it is very useful if the deviation affects, because again you can reinforce and you can splint it nicely, because the perpendicular plate of the ethmoid has this amazing ability of creating more tension and stabilizing, even in cases of post-trauma that you might have a fracture. At every opportunity, try to spare, because sometimes that need, as I said, for bigger surgery. So it might even rib or do a longer intervention.
I have to say, I've done this several times, and even just this week, bone to straighten out and crooked septum. Much recidivism of patients. Have you seen much? That's another question that just popped up. Any of the panelists?
I have not seen much. It's a good question. I believe I would be surprised if, I don't think it disappears. Maybe
I don't think so either. Yeah, autologous tissue is going to stay. Wolfgang, did you have a comment?
Yeah, I want to comment on that. First, congratulations, Filio. It was a great talk, and I think you showed it, but you didn't mention it, for the survival of the bone, that you thin it out. This is and perforations. The perforations help survival, and they to fix the fixation, because fibrous tissue grows through and therefore it is stable. And Charles East from London, he did a lot of research of this, and he found also bone gets not resorbed. And I think it gets not resorbed because it goes down when you thin it out carefully.
Excellent point.
Absolutely, absolutely. I agree with that anyway. Yeah, it's a wonderful material.
Okay, I think we're going to move on. Thank you very much for that talk and all the comments. It's my pleasure to introduce Dr. Robin Lindsay, who's coming to us from a small university called Harvard. That's the Stanford of the East Coast. That's what we call it. But Robin, thank you so much for joining us, and I look forward to your talk.
Thank you, Sam. So I'm going to talk a little bit about the use of PDS plate to reconstruct the septum. I have nothing to disclose. And I just wanted to back up a little bit and talk a little bit about that PDS plate is not a new product. These kind of animal studies were back in 2000, which is a couple decades ago, believe it or not now, were demonstrated too that the PDS plate absorbs over time in about 4 to 6 months, and therefore potentially decreases the issue with limiting septal growth over time. And so there's sort of an early manuscript looking at about 50 patients utilizing both perforated PDS plate and unperforated PDS plate. And you can see down to the bottom sort of the different forms that PDS plate's available in. And in this study, they showed that potentially there was a higher risk of infection with the thicker 0.25 PDS plate, and therefore recommended the 0.15, which comes as a rated plate. And so, the question really is sort of, which foil to use. Brian Wong at UC Irvine, looked at this in his lab a little bit further and literally looked at the stiffness of each of those two plates and determined that the 0.15 was 4 times more rigid than septal cartilage alone, and wasn't that much more. The 0.25 wasn't that much more rigid than the perforated. Clinically, I haven't found that to be the case, and so usually I do use the 0.25 unperforated because I find that for these difficult septums that really need a very rigid scaffolding, they need something that has more structural integrity to it than the 0.15 perforated plate. And so, additional studies have been done using, PDS plate in a variety of different utilizations, from septoplasty, either batten grafts to lateral curl strut. I can say the only thing that I use PDS plate for is really for structural support of the septum. And then also I will use them, which I'll talk about in a little bit, as Dean Torniumi has described, as for secure caudal extension grafts. And so this is the PDS plate product. I have not used the 0.5. I haven't found it necessary to use something that's rigid. And I kind of find that 0.25 unperforated really is what works in my hands. And if you go on their website, again, I have no disclosures, they talk about this, used for a variety of different indications. I really only use it for the septal support. And then Dean Torniumi published this paper several years ago, sort of utilizing the 0.25 unperforated plates, really to help secure the caudal extension graft, so you're not thickening that area where you're trying to open up the external nasal valve and not overlaying those cartilages. And I also, I've used it frequently for this purpose as well. One thing to keep in mind with PDS plate is I'm not sure the cost of it internationally. In the US, one PDS plate is about $500, so it's not inexpensive relatively, and so it's certainly not something that you want to be opened up on the table if you're not certain that you're going to use it, just from a cost utilization standpoint. I did used to perforate it with an 18 gauge needle, thinking that would help with vascular ingrowth, but I've stopped doing that over time and have not had increased issues with infection rate. So this is several years ago now, back in 2017. One of my previous residents, Jennifer Full and I, looked back at sort of our experience using PDF's plate and looked at 88 patients who'd had really a septal fracture or sort of with those kind of C or SH septal deviations. We used both open and closed approaches for these patients. All of my patients undergo sort of very standardized regimen of a standardized nasal exam. They all get preoperative nose scores, face Q scores. Now everyone gets a NIF. Were collected at pre-op and then at 2, 4, 6, and 12 months post-operatively in 2 years and 3 years. And so the intervention these patients underwent was correction of the L-strut deviations with the 0.25 PDS plate. We did have one infection and one revision in this study. So this is sort of looking at that patient population. You can see how they had dramatic improvement in their nose scores over time, really immediately at 2 months, and that those had stabilized out to greater than 12 months when the PDS plate had absorbed. And again, just kind of looking closer look at those numbers, demonstrating improvement in symptomatic nasal obstruction that was persistent over time. So this is sort of a typical patient with a history of septoplasty who had a high dorsal and caudal septal deviation that was not corrected adequately with the previous septoplasty, or potentially the septum moved after the septoplasty, but was still having persistent symptoms of nasal obstruction after the surgery. And he had a nose score of 100, which is severe obstruction, and his NIF was 60. And so he underwent a functional septal rhinoplasty with placement of the L-strut. And you can see here, this is how I typically carve it, really just sort of in alignment with the remnant L-strut. I try to leave at least 1.5 centimeters dorsal and caudally, if at all possible. And I only put it on one side of the septum. And I think that that's very important for that to decrease the risk of infection, is to ensure that you still have that sort of vascular supply from one side of the mucosa. And so with the placement of the PDS plate, I talk to the residents a lot when we're, even when they're doing the section, is the importance of not cross-hatching when you're doing a septoplasty. And oftentimes when we see revisions with this dorsal or caudal deviation, it's because when the septoplasty was done, there's either a fracture line or the instrumentation that was utilized for the septoplasty has gone past point, which now really creates an iatrogenic fracture line and causes curvature over time. And so the placement of the PDS plate is sort of right in that residual L-strut. And I typically just sew it, suture it into place with 5-0 PDS suture and a couple horizontal matrices to stabilize where is needed. And so this patient, 6 months post-operatively, was breathing much better, had a nose score of 0, so no symptoms of nasal obstruction. And you can see it also had increased with the NIF. And just to speak a little bit about the NIF that Dr. Most mentioned earlier, I also don't use it as a diagnostic, because I think that we've demonstrated through using this in hundreds of patients that it really doesn't correlate well to the nose scores. However, I do think it is useful pre and post. It's a very inexpensive tool to utilize in your practice if it's useful for you. And so here's another patient in intraoperative person where the open approach, the upper lateral cartilages had been released from the septum. And you can see how they still have deviation. And this is a person that, even after you take out and perform the septoplasty and with the remaining L-strut, still has a sort of SG-shaped deviation that really won't be adequately corrected with just the placements of spreader grafts alone. And so this is really another patient population that I utilize the PDS plate for, and suturing it to one side of the septum with the 5-0 PDS sutures to help to bring that in septum into alignment. And this is that same patient post-operatively with improvement in the nose scores and no change in the aesthetic appearance on the face Q scores. So this is just another patient, pre and post-operatively looking at had severe symptoms of nasal obstruction with a right dorsal deviation, and then at 3 years still had significant improvement in his symptoms of nasal obstruction and no concerns with saddle nose deformity or kind of loss of septal support. And then kind of similar patient there with improvement at 3 years and another at 2 years with those, dorsal septal deviations. And so a lot of the questions that we get about the use of PDS plate is, what are the concerns and what are the benefits of use? And so I think the biggest concern that you have is that you're putting a foreign body in the nose, which is not all of that clean of a place. And so is the risk of infection, saddle nose deformity if you lose the structural integrity of the septum over time for either or action. I will say that you do actually started using this more often. And I work very closely with our rhinologist, and we co-manage many of these nasal obstruction patients just based upon sort of my practice environment. You do get prolonged septal swelling on the side of the PDS plate. And so it's important to know that, because I think the first few patients, they would send over after they saw them and thought they had a septal hematoma. And so I'd see them and look, and they don't have a septal hematoma, or at least we did not have any that did. But it was just that septum on that side does stay swollen for a while. Also, if you have a rent in the septum, you don't want to put the PDS plate on that side. You want to put it on the side that you have fully intact mucoperiochondrial flap, because the mucoperiochondrium will not heal over the PDS plate, and it will not heal until that PDS plate dissolves. And it does take about 4 months or so. And then we talked earlier a little bit about the cost. It's not inexpensive. It's about $500 a sheet. And, the benefits is that, if you have a patient that just has a C or an S-shaped deformity, they've already had a septoplasty, you just need something to brace and really act as scaffolding for the patient, that it can avoid the need for a rib graft and increased cost and morbidity there. And then also, it does help you in some cases with those severely sort of fractured and curved septums, that really spreader grafts or even extended spreader grafts aren't truly bracing across the area that you need without significantly widening the septum. And I think this is really that area that you can also use if you have a nice thin piece of perpendicular plate of the ethmoid. You're really using it in very similar fashion, where you're taking your perpendicular plate and putting holes through it and suturing it to the remaining L strut. And that's it.
Thank you very much, Dr. Lindsay. That's great talk, and I think it brings up a few different points. I think the first point is that from all over the world, and we all have different ways of treating things, and it kind of shows that there's more than one way to attack revision septal surgery. We just saw a talk about using bones, cranial ethmoid bone to brace, and here we're looking at using a couple comments that are just when patients, or not just when doctors are doing L-strut septoplasties, observe more than a centimeter of this L-strut cuts or crosshatch. Dr. Lekakis mentioned the 2 centimeters she showed in hers, and I can't overemphasize that some of the teaching about leaving a centimeter, I think, is just incorrect. I think you really need to do more. A true L shape isn't really a great idea. I think a brace at the corner is important. At least I do a lot of revision septal surgery too, primarily using a modified extracorporoplasty method that I adapted after seeing Dr. Gubisch's work. I think that cross-hatching and weakening the septum isn't the way to go. So bracing it somehow is good. And I also like your comment about using the thick stuff. When this came, I was very excited about it, and I used it. I didn't have a great experience. Very thick stuff, and I noticed a lot of swelling. I've had 2 septal abscesses in my entire career of almost 20 years now, and they were both the first couple patients I put to. So I stopped immediately, and I haven't gone back. But your talk is very convincing, and I think about maybe using probably the perforated material. I think Wolfgang has a comment.
Yes. Sam, thanks. Robin, that was a great talk. I think I was the first or one of the first in Europe who used it in the early 80s.
Mm-hmm.
You mentioned the problem. I think if you have a perforation, it is obsolete to use PDS. Everything will melt immediately. Therefore, you're told if you have a laceration, put it on the opposite side. And you mentioned also it's much cheaper to use an ethmoid bone than to use this foil. Of course, the industry is not interested, but for us, we pay, it's not 500, it is 350 around, but it's also not cheap, and it is not covered by what you get from the insurance. Therefore, I think you should concentrate more on the bone, and if you have a bone transplant and you have a perforation, it will heal. But with the PDS file, it will not.
I think that if you have a nice thin piece of ethmoid bone, that works very well, and I would utilize that first. I think a lot of patients that we're seeing for revision nasal work, when surgeons are doing endoscopic septoplasties, a lot of time they're actually taking out the entire perpendicular plate. There's actually no ethmoid bone. And so I think it's really just to have another tool in your toolbox, and doing what's best for that patient at the time and what you have available.
But the problem where you need it are specifically secondaries. It's difficult not to lacerate mucosa, and therefore just in these cases they are not just ideal, because in many cases you will damage the mucosa in a way which and then you take the risk that you get an infection or everything melts and you have no stability.
Yeah, we have not had a high infection rate. I've gotten away on my primary rhinoplasties and even revisions that I'm not using rib graft or PDS plate. I no longer do postoperative antibiotics. They just get one dose IV intraoperatively. However, with PDS plate or with rib grafting, I still do use it as a little, whether I need to or not. I do send them home on a week of post antibiotics. But I really have an operative infection, and that one post-operative infection was actually at 3+ months after surgery, and was in who had initial trauma in gym, back in and drained the septal abscess plate at the time. Because he was in the access, we reported it, but when we went this plate, I think there is a risk when you're putting a foreign body in the nose, and certainly needed to take that into consideration.
I made a study and operated 30 rabbits and put there these PDS foil. But if a rabbit has a very thin mucosa, and you always make an injury to that. And after we killed them, we made the research. All the PDS foil has melted.
When it first came out, and I'm interested in your comments on this, Wolfgang and Robin, they showed images of a piece of PDF foil with 5 or 6 pieces of cartilage sutured to it, placed as an extra corporeal. My thought was that I didn't think there's any way that would heal into a secure, strong, something experience with that. In fact, scarred pieces of cartilage were somehow stable enough to support a nose.
I have no theory of 20, but I did it exactly. I also combined the residual parts of the septum with ear cartilage and sticked it on one PDS foil and put it back in a severe saddle nose. I will not mention this case in this. And it healed, and I've had 10 years.
That's great. Yeah, I mean, it just was hard now.
Yeah, see, I agree. I think I've seen those images too, and people show great results, but it always makes me nervous to have all those pieces on there attached to something that's going to absorb. And I think that's why I sort of, altered that technique a little bit and sort of used it as a shape of an L strut with just to support it that way, because it seemed a little bit more seized.
Yeah, that's really interesting. Thank you for sharing that. We're going to move on to us from Germany, and I have to say that Wolfgang's really influenced.
And total extracorporeal septal reconstruction are safe and reliable procedures with very good long-term results. This you find always in my book. Thanks for following me.
Thank you very much, Wolfgang. That's as usual amazing, and you have the we have the honor of seeing great results, but also the longevity of those results is really interesting. And your comment that the faces changed but the nose stayed straight, So,
You not recognize these people.
yeah, I mean, that's really great to have that kind of follow-up, and I hope that at some point I can do something like that. But I have a couple of questions that I wrote down. It's very interesting to me that one comment you made was you take the whole septum out before you address the hump, so that
In the
as you
beginning, over these 30 or 40 years, of course, if you resect the hump first, then the size of your septum is smaller. Maybe that you just resect a straight piece which you could need later. Therefore, and nowadays everybody is doing the by these other techniques.
As you know, I usually find technique and for septal reconstruction and taking the. So I'm wondering now about that. Part of the reason I do that is because I'm preserving the keystone area.
Yeah, but, of course, and that's a good idea.
Yeah, someone sent in a question. Let's see if this makes sense to me. Suturing the upper lateral cartilage, the septum, nasal bone, and crooked noses. Well, you kind of showed interesting in the transcutaneous. Thinks about it, you showed that to get across. And those are available. People can get those if they want.
Yeah, of course, of course.
Yeah. Now this is again bringing up this idea of craniofacial. I often find the nasal spine line up either with the philtrum or with the glabella. And so what do you do in those? We talked about the importance of the nasal spine. Do you refracture the spine, move it?
There are two options. If it's a small deviation or dislocation of the spine, let's say 2 millimeters, then you can do a side-to-side fixation to the spine. If there are 10 millimeters, then I cut the spine, I transfer it midline and fix it with a micro plate and micro screw.
Yeah.
And of course, then they're not stable enough. Then I fix.
You know, that's great. And I do similar. The one problem that I've run into is that sometimes just the lower face does not line up with the upper face. Is that I'm going to try to line up your nose with your Cupid's bow and your philtrum, even if that doesn't make your nose straight vertically because it was off center. Sometimes the piriform aperture itself is offset, even if you made it the door from the block 190. Do you ever do modifications of the piriform aperture? I've never done it. People talk about that. And what do you counsel patients about that type of asymmetry?
You are totally right. You need an exact and precise preoperative analysis. Then you see the problem, and then you can discuss it with the patient. If you don't do that, well, now my nose may be straight, but it is crooked. Then you say, if you tell him before that he cannot expect things symmetrical, he'll accept that.
Yeah, that preoperative counseling is very important. And I think you already mentioned this. Do you get CT scans on everybody then, or?
Well, my good friend Enrico Robotti I have not the chance to do, and also mention, I think you showed your patient, I wouldn't do that. And I totally, Sam, there are indications that not everybody has a cone beam. You have to go to the MaxFax and ask them, can I use your cone beam? This is not so easy. But if you have the chance, like Enrico, he has it in his hospital, then you can do it. But otherwise, I think, like Sam, I think it's not worthwhile to do it in every case, but we have to have this tool in our toolbox.
Yeah, and by insurance, so I don't think it would happen. Does anyone else have any other comments? Okay, well, thank you so much, Wolfgang. That was just fantastic. And our last speaker, last but not least, is Lucas Patrocinio, is coming to us from Brazil. And Lucas, you're going to talk to us a little bit about work now, right?
Yep. here we are. Can I go on, Sam?
Yes, please. Thank you.
Okay. For me, first, it's an honor to be hosted by Sam, one of the guys that most, and second, to be with Professor Gubisch. It's one of the guys that I most admire in my practice. He's been to Berlandia and it was fantastic for us. And finally, to be with three gals that are, well, we can say that being with gals that are extremely famous, for me, it's astonishing. Thank you for having me here. Sen asked me to speak a bit of rhinoplasty and other craniofacial surgeries. Well, what's happening? Oh, sorry. I'm from Brazil. I'm from the nose of Minas Gerais. My state's Minas Gerais. I'm in the center of the country. Fortunately, I'm at the nose, so I can tell you that we're a family. My father is currently the president of the International Federation of Facial Plastic Surgery Societies. My brother, the younger one, works with me, and we all do facial plastic surgery. And what I want to show you is how functional rhinoplasty can work with all the other craniofacial surgeries. Because a guy like this, his name is Joel, he has breathing problems, he has teeth problem, he has aesthetic problems altogether. That's his occlusion, that's his nose, that's his CT scan. So I have to help him in all the things I can help. But it's controversial. I know there are people that think that rhinoplasty should not be done with orthognathic surgery at the same time. Because when we move the maxilla, we do a Laform 1 osteotomy, we change the position of the septum, we change the position of the nasal spine, we change the position of the nose. But anyway, what we all look for is happiness, patient happiness. And I will focus on orthognathic surgery because we have 7 goals for orthognathic surgery. And the 3 last ones are facial balance, functional airway, and patient satisfaction. So why can I do an orthognathic surgery to a patient and not do rhinoplasty and not do septoplasty or endoscopic sinus surgery? I cannot do this, in my opinion. I would do half of the operation. And we all know that when we do orthognathic surgery, aesthetic effects in the nose when we move the maxilla. This is a regular patient with a bad outcome on the nose and she had an orthognathic surgery. Look, she has a saddle, she has an overprojected nose, has a bad defined tip. So really what happens when we move the maxilla, that the tip rotates or it under rotates. It depends on the movement, what we do in maxilla. For example, in this patient, we've moved the maxilla forward for orthognathic surgery. It's okay for her, the tip moved upwards. For her, it was okay. For this guy, it was an MMA, maxillary mandibular advance for sleeve apnea. Oh, it's okay. Nasal dorsum. Usually when we put the maxilla up, we have a hump. When we move the maxilla down, we have settle. For example, in this case, we have a reduction of the dorsum. It was good for him. But for her, no. That's a patient of mine. I did an MMA and a brown lift, and she had a settle that was not good. And for the alar base, that's usually not good. For example, it's another patient of MMA. Look at his nostrils. The alar is very wide now, I think that's a good option to do just the orthognathic surgery by itself. So that's my sequence. I do the orthognathic surgery first, I change the tube, and then I do the rhinoplasty. That's my draping for the orthognathic surgery. That's my leaf 4-1. That's my sagittal split osteotomy and my chin osteotomy. And that's how I change the tube from nasal to oral. I usually don't do a second intubation. I prefer to put a tonsil elevator or tonsil gouge, and I use a Kelly clamp, a long one, to fix the tube on the hypopharynx, and I use another tube to pull the tube to the mouth. So it's very easy, it's very quick, and I usually, the anesthesiologist usually doesn't participate on that, and then I disinflate the balloon and I put it back. So it's good, and then when I finish the orthognathic, now I'm ready to do the rhinoplasty. The most important thing, if I can give you guys, I know you, most of the people that are watching don't do rhinoplasty and orthognathic. I do both surgeries, but mostly one do this or the other, but you should have a partner to do both surgeries at the same time. That's the main goal I want to show you guys. That's important because it's facial balance, it's breathing, it's functional. If you don't do this, you have to have a guy to do the orthognathic or to do the rhinoplasty. And the main thing I want to give you guys is to fix this to the nasal spine. We all know this, but in orthognathic, we totally separate the nose from the nasal spine. So it's, as Professor Gubisch has showed us, we have to fix it. And we have to take our graft. So what I usually do, I dissect from the oral incision, both mucosa flaps, and I dissect submucorundal flaps, and I try to set the projection and rotation when I fix to the nasal spine. It's usually not possible, but sometimes I can't, and I decide that I have not my 1 centimeter, my 2 centimeter caudal, and I fix it to the spine. So I agree, 1 centimeter is not enough. I usually leave 2 centimeters because most of my patients are Africans or thick skin patients, and the septum is not that good. Anyway, so that's why I usually do septal extension grafts. And for that, in my patients, there's a good option that we've been talking the whole webinar now, that we need a bone. We're using PDS plate, we're getting bone for perpendicular plate, but I do not do this, but I prefer to, we have a good donor, which is the medial wall of maxillary sinus. So I use the piezo, I take, it's a thin bone, and I can use it to, all our panelists here have shown us how to do it, but it's a good donor site. So I have a great thin plate of bone. I can take from the perpendicular plate too, from below. But when I take it from the middle wall sinus, it's perfectly, because it's thin. I can just put the holes. I don't need to thin it. And I usually put them first at the nasal spine. So I have a good buttress to stabilize the anterior nasal septum. And then I can use for spreader grafts, I can use for septal extension grafts, but especially to stabilize the base of the nose. And that's awesome, because I have a graft that I couldn't even have if I just did rhinoplasty. And the other thing is that when we do, is that we have a plate here. We will have a plate on the nasal max buttress. So we have to be careful. But as long as we have an intraoral incision, we can do the high or the low incision. We can do both of that with intraoral exposure. But I usually do, as I learned with all those guys from full open approach, I will do low, low, and then high. And I do those osteotomies from inside. And I just finished with the high, with the piezo, with a full open approach. So I do both incisions, and I do both osteotomies, intraoral approach, and then the other one in full open. And at last, I don't do Sinus surgery. We usually do Sinus suture when we do orthognathic surgery. But when we do rhinoplasty, I don't do it because they are not reliable. I prefer to do alar-based reduction as we do usually. So I'm going to show you a few cases. A girl with a class 3 maxilla hypoplasia, vertical excess of the face. That's her smile and profile view. That's her bite. So for her, I did maxilla advancement and just chin. I advanced 7 millimeters maxilla and I shorted the chin. And did, of course, rhinoplasty at the same time. That's her. It's shorter face, better balance, better occlusion, better profile view. We also have a lot of patients that we all do facial plastic. Usually patients come with gummy smile. These patients should be treated with orthognathic surgery and rhinoplasty, in my opinion. She doesn't have lip occlusion, so we did, she has you can see that she has a polybeak, but it's just the anterior septal angle that's supporting her tip. She doesn't have tip support. So I did for her, I put the maxilla up, I put the maxilla forward, I put the mandible forward, and I did the rhinoplasty at the same time. So now I have a better smile, a better tip defining, the tip is more defined. I have a better occlusion, the lips are sealed, a better base view, and on profile view, it's awesome. So I think gummy smile is the best thing that we should do all the things all together. This guy, he has an open bite and a pinched nose, secondary nose. What I did in, I just did a maxilla surgery to close the bite. At the same time, I did a seagull wing graft. And now he has a better occlusion, a better breathing, because I correct the external nasal valve. His occlusion is better. His nasal valve is better. And at the same time, we refine the rotation and the supracipitary. And last, the patient that we saw at the beginning, Joel, he's a guy that has several problems. He has breathing problems. He has bite problems. He has aesthetic problems. So why not solve all the problems at the same surgery? That's his occlusion. That's him before we did the operation. That's his decompensation for the surgery. That's his bite. And for those that don't know, we usually do pre-surgical virtual planing. We get the CT scan, the 3D photos, the scan of the occlusion, and we do virtual planing before. So we can see where the bone will be. We do the osteotomies, we can see how the bones will be. we have estimation how the soft tissues will be like this, and we produce splints that will make our bones to be at the same position that we want. And we have an estimate. It's not good, but we have an estimate how the maxilla and the mandible will move. And so we went for rhinoplasty and orthognathic surgery. That's the LIF41 osteotomy, the spleen in occlusion, grafts in position, fixation, mandible, another spleen in occlusion, and that's it. We did maxilla and mandible. We did not do chin. That's important. We did not do chin. And we can move all the facial planes so we can have a better balance. We have a guy now that has a shorter face. His chin is centered. It's not long as it was, it's shorter. We have a good columellar relation to the labial angle. We have a better smile. We have a better profile view, a better reduction of the dorsum, better occlusion, and a better breathing. So I think, in my opinion, that if we can merge all these surgeries at the same time, we're going to have a better patient. He's going to have a better occlusion, a better breathing, and a better aesthetics. And that's why I try to do all the same surgery. Most of the surgeons don't do at the same time. The same thing that I did with, I said with CRS, because it's a big operation. It usually takes me 3 hours in orthognathic and 3 or 4 hours in rhinoplasty. I think 6 hours is okay, but it's usually a big surgery. But usually my patients are very happy, and I usually recommend that you guys do the same thing. Thank you. That's my connections. Thanks, Sam.
Thank you very much. I think it was great to kind of wrap up with your talk, because it covers so many things and introduces some new concepts. We've been talking about facial asymmetries the entire morning. You mentioned how long it takes. One of the questions from the audience that came up while you were speaking was, do you have any increased infection rate or concern about that?
No, I don't. I don't think, I think the same thing that I answered when on CRS. I think the problem is the length of surgery. I have friends that do orthognathic surgery in 6 hours, 7 hours. Not advisable to do both surgeries at the same time. But if you have a lot of experience, you do surgeries all days, and if you do orthognathic on 3 hours, I fast at the same time, because it's 3, 4. It's okay.
Yes, I do combine functional endoscopic sinus surgery. I know you're familiar with the sleep and the sinus guys here at Stanford. I mean, I think one of the important points you make is the effect of the craniofacial skeleton on the soft tissue shape around the nose and projection rotation. Patients that come to me for correction of things that were done after ortho. And, you know, I think it'd be really, I don't know if anyone's codified the things that you wrote in your slide, but really to show perhaps less literature, but what the effects are exactly with each of those maneuvers, because it hasn't really completely made sense to me. I think part of it is because different things are done to the septum, and your comments about fixing the septum, I think, are very important. I know that everyone in this panel really knows that, but really the effects in the septum are the things I often end up having to correct. Have you met other people that are doing everything that you're doing at the same time? I don't know too many people that are doing that. You know, my skill set doesn't include the things that you do. I have colleagues at Stanford that do that, and so they usually, I tell them to do all their work first, and I'll work on the nose 6 months later, because I want to. The predictability of doing all of this is just one of my concerns, and I don't know. What are your comments about that?
Few things. First, if coming to find a guy that do both surgeries together. I have friends that work together with ENT guy, Jose Barreira is a great guy. But he's not doing it does not do at the same time.
One of my former fellows.
Yeah,
probably one
of your fellows, probably. He's a great guy. What I think, Sam, it doesn't matter, because when you move the maxilla, you have a new nose. But for us that do surgeries all day, it doesn't matter the starting point. For us, it's the end point that matters. For me, if it's a nose that's like this, and then it's like this, it doesn't matter. I'll get my end point. I just have to have my, all my guns, all my grafts ready. That's why I try to show that bony grafts from the maxillary side, straighter septum, enough better, stronger nasal caetal. The septum be enough, I'll go for cartilage. So okay, it doesn't matter.
I actually had a question about that. When you take the medial wall of the maxillary sinus, are you leaving the mucosa intact somehow, or are you taking the whole wall down? I'm sure Kate may have a comment about that if you're taking the whole thing down. Oh, I think Luke. He's frozen on my screen. He is on yours. Hopefully he can rejoin.
He looks frozen.
Oh, there he is. You're back. Okay.
I think my connection was lost, probably. Okay. I couldn't understand.
The question I had was
the maxillary sinus.
Yeah. Does the mucosa stay intact so you have a wall there? Or? Okay.
Yeah. We usually do this in orthognaths, especially in infections. When we have gummy smile, we have to take the maxillary sinus walls and we leave the maxilla. I usually use them for rhinoplasty.
Very, very interesting stuff. Wolfgang, do you have a comment?
Yeah, well, I think there are only really a few tough guys like you. I saw you operating and I know you are an excellent surgeon, but there are only who are able to do that. If you do a Leffler one, you have to, otherwise it doesn't work. And then you have the best ones, and there you are totally right. If a maxfax doing that, who has no idea from the septum, he does something to the septum, and then you have to revise it. It's much better if you do that. Who is in the maxfax, like I'm in nose, it's not so. You are very experienced in both, but you have to look around. There are not many.
Yeah, unfortunately, are retiring, so we cannot join forces again.
I'd love to be a fly on the wall for that one. That'd be fun.
I'll retire. I'll retire.
Does anyone else have any other comments? A couple of things. First, say that one of the things I think that came up, throughout this is that form are both important, and so we seldom work on one without affecting the other. They should always be considered, as I mentioned at the beginning, and so I applaud everyone for that. I think that everyone's shared their knowledge, and thank you all. I always learn so much. Some of you I've seen speak still learn new things, so I thank you all for time on the Saturday, wherever you are, for sharing things with us and with our audience. I know there's a lot of interest. We don't have time to answer all the questions as we've already run over. Thank you all very much for joining. Thank you to Sachi for setting this up and spending a Saturday. This is the last in our series for now. We might reintroduce these later this fall. And I hope you're all safe, and I look forward to seeing you all in person when the COVID thing's under control. So be safe, and thank you very much.